If you've ever looked at two people who are exactly the same age, same decade, same rough genetics, same sun exposure, and wondered how one of them managed to keep a jaw angle that looks 35, while the other is fighting a neck that's gone soft and forward, the answer almost certainly isn't where you've been looking for it. Press 2 fingers into the crease where your hip meets your thigh, right where you fold when you sit. Press in, hold steady, and now, slowly, roll your shoulders back. Feel that? Something releases in your throat. Not your throat exactly, higher, the space under your chin. There's a pull there that most people have never named, and it connects to what you're feeling in your hip right now. That connection is what this is about. The structures that define a lifted jaw angle, the ones that keep the neck long and the submental area flat, are not malfunctioning in isolation. They are the terminal end of a mechanical chain that begins considerably further down the body. And if the chain is under load at its origin, you can treat the terminus all you want. You'll be treating symptoms. How is that anatomically possible? That's the question we're sitting with, because the answer changes what you do next. The first serious surgical attempts to address what we now call cervical aging began in the early 1900s. Charles Miller, working in Chicago, was documenting procedures for excess skin removal around the neck and face as early as 1907. Eugen Hollander in Berlin published similar work. What unified all of these early practitioners was a shared anatomical assumption. The problem was local. Gravity pulled tissue downward, time reduced elasticity. The intervention, logically, was at the site of the problem. That framework held for over a century. It got more sophisticated. The SMAS layer was identified in the 1970s, giving surgeons a deeper plane to work in, producing longer, lasting results. Devices for external tightening evolved. Injectable options multiplied. The entire industry of neck and jawline care is built on the premise that what you see is where the problem lives. And the premise isn't wrong. The tissue is genuinely different. The muscular support is genuinely reduced. The skin has genuinely changed. None of that is fabrication. What the anatomists working in those early decades could not have modeled, because they had no reason to, was what 8 hours a day of sustained hip flexion would do to the body's anterior tensional system across a working life. They were describing aging in bodies that moved, bodies that farmed, that walked long distances, that rose and lowered from the ground routinely. They weren't describing what happens to a body that spends 30 years in a chair. That body is a different mechanical problem entirely. The iliopsoas is 2 muscles that function as one. The psoas major originates along the transverse processes and vertebral bodies of the lumbar spine, roughly from T12 down through L4 and L5. The iliacus originates from the inner surface of the ilium, the large curved plate of your pelvis. Both of them pass forward under the inguinal ligament, that's the crease you were pressing a moment ago, and attach together onto the lesser trochanter of the femur. When this complex shortens, which it does when it is maintained in a shortened position for long enough, the mechanical consequences are sequential and precise. First, anterior pelvic tilt. The iliopsoas pulls the lumbar spine and pelvis into forward rotation. The top of the pelvis tips toward the floor, the bottom tips backward. This is not subtle when it's moderate to severe. You can see it in the lower back curve of people who have held office jobs for 2 decades. The lumbar lordosis deepens. The pelvis is being pulled forward by shortened hip flexors. That pelvic change then loads the thoracic spine. A pelvis that is anteriorly tilted reduces the mechanical basis for maintaining an upright thorax. The thoracic spine flexes forward, kyphosis increases. Not dramatically in early stages, incrementally, over years. The forward translation of the thorax is the second link in the chain. The head then follows. The skull sits atop the cervical spine, which is now positioned on top of a thorax that is increasingly forward relative to the pelvis. To maintain forward gaze, the head protrudes. Cervical protraction, forward head posture, is not primarily a neck failure. It is a downstream consequence of a thoracic failure, downstream of a pelvic failure, downstream of a hip flexor problem. It is the fourth link in a four-link chain. Now consider what happens at the anterior cervical fascia under that load. The fascial system running from the suprasternal notch upward through the neck is maintained in a state of chronic compression when the head is forward. The platysma, the thin sheet of muscle that covers the anterior neck, is chronically shortened on its upper attachment and chronically stretched at its lower one. The digastric, the mylohyoid, the geniohyoid, the suprahyoid musculature that creates the angular definition between chin and neck is under reduced mechanical advantage. The submental region fills, not because fat has accumulated there, though it may, because the scaffolding that held it taut is no longer positioned correctly to hold it. The visible angle between the bottom of the chin and the top of the clavicle, the thing surgeons are trying to restore, the thing every device in that category promises to address, is a geometric consequence of where the head sits relative to the thorax, and where the thorax sits, and where the pelvis sits, and what the hip flexors are doing at the base of it all. That is the chain. Every link is established anatomy. The consequence at the top is the one you see in the mirror. Wait, I should back up before the protocol. There's something about how this loads differently in different people that changes which part of the framework you use, and I want to get to that before the release itself. She came in having tried what felt to her like everything. 2 rounds of radiofrequency tightening, a year of consistent neck-specific exercise, a diligent skincare routine that genuinely addressed the tissue quality. None of it had given her what she was hoping for. A sustained change in jaw definition, a neck that looked like hers from 15 years earlier. She was in her mid-50s. She had a desk job she'd held for over 20 years. Her commute was long. She had children who had needed her for years in ways that meant she sat and bent forward and carried and sat again. The moment we assessed her hip flexor length, what we found was predictable in retrospect and surprising to her. She could not achieve a neutral pelvis standing without significant effort. The anterior tilt was structural, habituated. Her body had adapted to 30 years of hip flexion with such efficiency that the shortened position was now the resting position. She didn't transform. I want to be precise about that rather than give a vague impression of reversal. Her resting cervical posture improved by measurable degrees over 16 weeks of consistent release work. Her submental angle, the visible angle under the chin, changed enough that her partner noticed before she told him she was working on anything. The expensive treatments she'd had before hadn't been wasted. They'd addressed real tissue issues, but they had been working against a load they couldn't see and hadn't been asked to address. She's not unusual. The specifics vary, but the pattern, decades of sitting, progressive anterior chain shortening, cervical changes attributed entirely to local tissue, appears consistently across the people I've worked with in this kind of assessment. It's not everyone, but it's common enough that not screening for it feels like an oversight. There's a way to understand what a chronically shortened hip flexor feels like from the inside that has nothing to do with understanding it intellectually. Hold a position of mild contraction for long enough, and you stop feeling the contraction. The muscle has stopped reporting effort because effort has become baseline. Your nervous system has recalibrated. What felt like gripping feels like nothing, because nothing is now your normal. That's what occupying contested ground for years does to a soldier's perception of effort. The reports from military medical officers working with infantry in the First World War documented something that seems obvious now, but was striking then. Soldiers who had held static defensive positions for extended periods, weeks in the same trench orientation, the same crouch, the same forward lean, could no longer perceive their own postural abnormality. The position had become neutral to them. Their proprioception had been recalibrated by sustained load. The body does the same thing. Your iliopsoas has been contracted since roughly the time you started your career. You don't feel it contracting. You feel nothing. You feel, if you notice anything, a vague tightness in the lower back sometimes, which is where the psoas originates, pulling on the lumbar vertebrae with no corresponding posterior force to balance it. But the hip crease itself, silent. The load is there, the silence is the adaptation. This is why the release feels so disproportionate when people do it correctly for the first time. It's not that the technique is especially powerful. It's that the system has been under load for so long that releasing even a fraction of the tension creates a change the body can feel from the hip all the way up the chain to the throat. Like releasing the compression on one end of a load-bearing wall that's been holding more than its share of the structure's weight. You feel the shift in the ceiling, not just the wall. The 90-second release is a framework, not a single fixed technique, because the hip flexor shortening that matters most varies by person. 3 questions tell you which end of the chain is driving your pattern. First, where does your pelvis rest? Stand against a wall. Heels, back, shoulders against it. Can you get your lower back flat against the wall without forcing it, without bending your knees, without tucking deliberately? If there is a gap your hand fits through easily, 2 inches or more between your lumbar spine and the wall, your anterior tilt is structural. The psoas is the primary driver. Your release targets the deeper hip flexor in a low lunge with the pelvis in posterior tilt. Second, where is the tension move when you walk? Take 20 steps. Do you feel the restriction in your hip at the top of the swing phase when your leg comes forward? Or is the restriction more at extension at the moment the back leg trails? Restriction at swing phase is primarily iliacus. Restriction at extension is primarily psoas. The release position shifts accordingly. Iliacus releases more readily in a side-lying hip extension, psoas in a standing or low lunge stretch with deliberate lumbar positioning. Third, does the tension live in your throat or in your lower back? This sounds like an odd question. Most people with significant anterior chain load will notice that one or the other is their primary symptom site. Lower back dominant, the lumbar psoas attachment is your priority. Throat and submental dominant, the chain is already translated forward to the cervical segment, and you need to work from both ends. Hip release combined with suprahyoid release in cervical repositioning. The 90 seconds is the minimum effective dose for the hip release itself. Not because 90 seconds is a magic number, because it takes roughly that long in a correctly positioned stretch for the nervous system to shift from guarding the stretch to tolerating it. The first 45 seconds, you're arguing with protective tension. The second 45 seconds, something actually releases. People who do 30-second hip flexor stretches are stopping right before the work begins. Apply the framework daily at the same anchor point after you stand from your longest sitting block of the day, whatever that is. The trigger matters as much as the technique. A release you remember to do because the workday just ended will happen. A release you plan to do before bed often won't. Both things are true. The neck has a real problem, and the hips are where a significant fraction of that problem originates. These are not competing claims. They are the thesis and the antithesis of the same mechanical story. And the synthesis is this. When you only ever address where load manifests, you leave the source of the load running continuously, feeding the same problem back into the same tissue. The people for whom local interventions hold longest are, in my observation, the ones who also happen to have addressed the chain upstream, through sport, through movement practice, through a job that required them to stand. They got the benefit of both without naming what they were doing. You can name it. The 90-second release is not a replacement for everything. It is the upstream intervention that most people working on the neck are currently skipping. And if you felt the release travel from your hip crease to your throat when you pressed in at the beginning of this, you already know which category you're in. Some people won't feel that chain. For them, this is one tool among many. But if that connection was immediate, if pressing into the hip crease moves something in your jaw angle or your throat, then you are not at the end of the problem. You are at the beginning of addressing it from the right end, and that is a different kind of work and a more durable one.